Welcome to our webinar titled Ask the Transplant Expert. Thank you for joining us today. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you lose your connection, you can log in and hear the program using the call-in number in your reminder email. During the presentation, there will be no formal presentation. It's just strictly a Q&A, an interactive webinar for you to have the opportunity to ask our expert your transplant questions. To submit your questions, please use the Q&A window in the lower part of your screen. And when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, please submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Our specialist today is Hemant Murthy. Dr. Murthy is an associate professor at the Mayo Clinic in Jacksonville, Florida. He's also an associate professor of medicine at the Mayo Clinic School of Medicine. As a hematologist-oncologist physician, he specializes in treating patients diagnosed with leukemia, lymphoma, myelodysplastic syndromes, and multiple myeloma. He has a special interest in bone marrow transplant and CAR T-cell therapy. Dr. Murthy also serves as an advisor on the AAMDSIF Patient Education Council. It's our pleasure today to welcome Dr. Murthy. Thank you so much for joining us today.
Thank you. It's a pleasure, and I really do enjoy doing these kind of things because I think whenever we have patients who are in need of a bone marrow transplant or undergo a transplant, the more information that we can provide, the more even reassurance that we can provide before the transplant, the better I feel like things are going through a transplant. And it is a process. It is something that it can appear quite scary, but I think given the potential of what a transplant can do for these diseases, and we talk cures with a transplant, I think it's important that we can try to give as much information and as much knowledge as can be. So thank you for kindly inviting me.
Oh, our pleasure. Our first question we have is, what is the difference between a bone marrow transplant and a stem cell transplant?
So the words are often used interchangeably. All the transplants are stem cell transplant. The reason we call it bone marrow transplant is because previously the majority of these transplants, the way we would obtain stem cells would be to harvest them through the bone marrow. And in some cases, donors, we do still obtain bone marrow grafts, particularly for patients who are undergoing transplants for aplastic anemia. But in the end, whether we collect it directly from the bone marrow or we collect it through something we call stem cell mobilization and collecting it through the peripheral blood, they are all hematopoietic stem cell transplants. So but if you hear bone marrow transplant and stem cell transplant, often the terms are just being used interchangeably.
Thank you. Another question we have comes from a patient who has had already a transplant, and they would like to know when and if it's ever appropriate to abandon prednisone and use other agents to try to help with moderate GVHD.
So this is an ongoing thing about when to, about the management typically of initially diagnosed graft versus host disease is corticosteroid. Now, there have been studies about using other agents first line, and I think that's a discussion to have with the transplant physician. For me, when do I go to things other than prednisone? It's if the GVHD is not responding to prednisone, or, and that would we call steroid refractory, or if you are trying to take somebody off of steroids and the GVHD recurs, which we call steroid dependent GVHD. So those are certainly the two main times that I would say we need something other than steroid, because we don't want to keep somebody on steroids long term, that there's so much deleterious effects of chronic long-term steroid use. So those are really, I guess, the two main scenarios. If it's not responding, or it flares or recurs as we're tapering the steroids off.
Thank you. This question says, can you please explain a 10 out of 10 donor match? How is it determined, and how does that inform the potential issues that might develop during a transplant?
So 10 out of 10, so, it used what we're talking about is HLA matching. Now, we used to, back early, we used to only look at 6 HLAs at 6 out of 6, so A, B, D, R. And when we talk HLA, we talk about HLA matching at A, B, C, D, R, D, P, and DQ. And there's two there's one set that comes from your mother and one set that comes from your father. So there you hold 2 copies. So that's where 10 out of 10, 12 out of 12 matching comes in. And that's what we do with our HLA lab. We'll take your sample, we'll take a donor sample, and we will look at the specific haplotypes, and we will see whether they truly match or not. What matching comes in is the more you match, the less risk of transplant related complication. It's not a guarantee. And I think nothing in medicine, nothing in cancer I would ever say is a guarantee. But what we do say is odds. Your odds of developing graft failure, which can happen with more HLA mismatch, with developing severe graft versus host disease, both acute and chronic. The more mismatching you can have, more what we call a graft versus leukemia effect, but it could also increase the risk of a toxicity. So ideally, we want a full match donor. Related sibling donor would be preferable, but full match unrelated donor still would be ideal in order for people to go to transplant. But that's why we do the matching. We do it so we reduce the risk of severe graft versus host disease. We reduce the risk of primary graft failure itself.
Thank you. Could you speak regarding any data for the success of transplant for patients with MDS in their late 70s?
So there, I want to say that, late 70, I mean, I guess define late 70, because the recent study that was just published from the BMTCTN was, if I recall right, age 60 to 75, where patients had a biological assignment to transplant versus no transplant. And the benefit was clear in survival and outcomes favoring transplant versus no transplant. I think anything beyond that, it really becomes it becomes a judgment call. And I think it's difficult for a transplanter to make the call, because age is just a number. We all say that. But age is a factor, and more so your performance status, how active you are, more so your coexisting health conditions. They all probably play a very prominent role in the likelihood of success of a transplant. The way I explain to patients is like this: everybody can climb into a boxing ring. Everybody can take one punch. How many people can get up and take a second punch? And that's why we when we screen patients for transplant, we check their organ function, heart function, lung function, because we know there are going to be insults. There are going to be times when there's going to be fevers, potentially infections, fluid imbalances, and the strength of a person undergoing a transplant is how resilient they are to withstand toxicities to be able to derive the long-term benefits. So in essentially, I think there are exceptional candidates who even in their late 70s, even early 80s, who we think, okay, they have enough of a reserve that they can probably handle some things. But I think I'd be remiss by saying the older someone is, the more likely that they would have difficulty handling intensive treatments. And a transplant, even in a reduced intensity, is still an intensive treatment.
Thank you so much for that answer. The next question is, how does morbid obesity affect the outcome of a transplant?
It's a risk. It's you know I it's interesting because morbid obesity is does affect outcome of transplant by way of, we have what's called an HCTCI, or comorbidity index, that helps predict uh, for outcome, survival, and transplant related mortality. And any score 3 or above makes you high risk for for higher treatment related mortality. Obesity, which for us, for the score, is defined as a BMI of 35 or greater, that gives you a point. So it's not a contraindication, but it does add some risk. And if there are other risk factors on top of it, then yes, then that can be a contributing factor. If you look at just BMI alone, though, I think you have people who have worse outcomes are actually very underweight patients, like BMI of 19 or lower. So I think, weight is something I would say, yes, it can be a risk factor, usually in the presence with other risk factors. Like if you had it with cardiac or diabetes, then yes, then that becomes more of an additive risk factor. But I think, I I also I think it becomes more of a thing also for long-term health. And I think that's what we sometimes forget about, because we're so tunnel focused on treating the cancer and treating the transplant. And I often, when I get a patient to a year past post-transplant, I've often said, we've been very focused on this, on your cancer, on the transplant, and it's now time we need to get the rest of your health like better and in the survivorship phase. So I think, addressing being overweight the best you can, dietary changes, exercise, I think it helps everything. So, but it's not an outright contraindication to a transplant, but it does carry some risk.
Thank you very much for that answer. What are the special challenges with a bone marrow transplant for a PNH patient?
Uh, I think it's a, it. I think it. I don't know if there's like challenges for PNH. I think it's different. I think what I would say is there is inherent differences in transplants for non-malignant conditions. I mean, and I don't like saying benign, but compared to there's differences when you're dealing with that versus dealing with things, say leukemia or MDS, where it's more of a malignant process. I think in PNH, probably things we would worry a little more about would be engraftment and immune reconstitution. But in essence, I, the reason I think there are less concerns disease wise is because transplant is almost is a modality. You know, we tailor some treatment plans particularly to diseases, yes, and we would do the same with with aplastic anemia, Fanconi. uh, they would be different transplant approaches, but in once the transplant starts, it's a lot of it is the same afterwards in terms of making sure that the patient has engrafted, making sure that their graft is fully donor, making sure there's no disease recurrence, making sure that we are preventing, or if or it comes up, that we treat graft versus host disease. So everyone may kind of start differently from an allo transplant, but then processes kind of become more streamlined and more similar after the transplant, just because it what we're talking about is less of a more of a modality than specific disease.
Thank you. Is it important for the blood donor type to match the recipient? And what are the implications if the blood types do not match?
Uh, it's important, but not. So I think so. A transplant plan is kind of like a recipe, and lots of ingredients, lots of different factors that go in. We do look at blood type, but we look at other things. I mean, I think more importantly is the HLA. I mean, if we that's the HLA matching is the probably the most critical part. And then there are other aspects that we look at. We look at the sex, male to female, female male. We look at CMV status, whether the patient and the donor are CMV positive, CMV negative, or CMV mismatch. We do look at blood type mismatches because differences in the mismatches, one, can potentially affect risk of graft versus disease, but also it can affect the whether when lysis of lysing of cells and maybe transfusion reactions, and different types of things where we deal with ABO major or minor mismatches. So it's important. It's something we have to consider with the transplant plan. And if all things are matching, we would like the blood type to match. But I think if we have limited donors and we have an HLA mismatch and a HLA match, but we have a mismatch in the blood type, I'm okay proceeding because the HLA matching is more important than the blood type.
Thank you. Our next question comes from a patient who is 51 with no comorbidities. They've been diagnosed with MDS unclassified, intermediate risk, and they're currently just on watch and wait. They have a number of 10 out of 10 matches for unrelated donors. They're relatively healthy. Their team has indicated that CAR T may not be appropriate for this patient. They're finding this confusing given what they understand is positive results. They'd like to know CAR T. They'd like to know what your perspective is on CAR T for transplant for MDS patients, and do you see this eventually becoming a standard of care?
So there is no approved CAR T for myelodysplastic syndrome. I think even clinical trials are really, they're more the clinical trials right now for CAR T is more for acute leukemia. Some trials are allowing relapse refractory high risk MDS, and usually those patients will have failed hypomethylating agent at least. But those again are still in very early clinical trials. So I don't I don't see any role right now in any standard of care for CAR T for myelodysplastic syndrome. Uh, the transplant question, I think that's another question in terms of candidacy for transplant, and that really depends on the risk factors. There have been some MDS patients that we don't need to treat, and we can go straight into transplant, but that you know I think certainly the risk by the revised IPSS criteria. And I think if there are some, in some borderline cases, if there are some high risk mutations that are present, then I think a transplant can be considered. I would also look at whether, like, how many blasts are in a bone marrow, or if there are any circulating blasts. Those things certainly would also play a part in that. Uh, that's at least for transplant, but for CAR T specifically, I don't see a role right now other than in phase 1 clinical trial, and they really would only be for high risk MDS that have failed therapy, that are refractory to therapy.
Thank you very much. This question comes from a patient who is now 37. However, they were diagnosed at 20 with aplastic anemia. At the time, they did not have a full match for a transplant, so they've undergone 2 rounds of ATG horse, once in 2008 and 2010. For the last 10 to 12 years, they've been on cyclosporine, but the medical team feels it's important to get off and possibly now look at a transplant. Brother is a half match, but they feel they may find better matches on the registry. The question is, how successful are transplants after so many years being out from diagnosis? And do you have any suggestions for questions for them to ask the doctor? And maybe is there something to do differently?
It's an interesting question. I don't know about like someone who's been diagnosed that long, still deciding transplant candidacy. I think certainly if it's still requiring cyclosporin, then I do think that it's certainly worth the discussion about transplant. What we know now is that, we know that haploidentical transplants are feasible for aplastic anemia, and a lot of this is thanks to work of Amy DeZern at Johns Hopkins, who's really been one of the forefront of haplotransplants for aplastic anemia. So I think, that's certainly she would be one of the foremost people that I would go to if that was a consideration. What was the other question?
Do you have any suggestions on the questions that they maybe should be asking the doctor, or any suggestions on anything to do differently?
I think the question is, if the transplant is, if the patient's relatively healthy, if the patient is needing cyclosporin to, I would really want to know, is the transplant indicated still? I think if you're still requiring immunosuppression medication, it's one thing for being on this long, and I think it's a discussion between the patient and the transplant center on whether they think a transplant, the pros and cons really of it. A transplant is a curative. It can cure this disease. But it does come with risk. And after being on this so long, is the appetite for going through a transplant like there, or do they want to wait for some, you know, do you wait for something to turn? I mean, then again, being on long-term immune suppressing medications is still a burden. It's still a risk. So I think that, yeah, though those would be. I think also the donor question are, if the reason for not pursuing if the only reason for not pursuing a transplant is a lack of 10 out of 10 donor, I don't think that's really that much of a, I don't think that's relevant today, given the success that we have seen already with the haplo transplants for aplastic anemia. And if there's anywhere that really can provide a lot of more of their experience in that, it's Johns Hopkins, and particularly Amy Dezern.
Thank you, Dr. Murthy. Our next question is, if a patient has hemochromatosis, does that affect the probable success of a transplant?
It can. The certainly iron overload, depending on the amount of iron overload, depending on if there are organ manifestations of it, if it is depending on the severity, if it's caused, cardiac issues, and that could certainly affect it. Liver, if it caused liver issues, if we see somebody with liver fibrosis or cirrhosis, that's a very concerning thing with somebody going into a transplant, especially considering some of the chemotherapies that are used in the conditioning can induce liver toxicity. So if it's mild hemochromatosis, or sometimes heterozygous, they may not have much manifestations from it. But if it's severe, if it's true hereditary hemochromatosis, and they have significant iron overload or involvement in their organ, it can potentially affect the outcomes of the transplant.
Thank you for that answer. Our next question reads, this patient has high risk MDS and had a perfect match sibling transplant after 6 months of Vidasa. Things were very good initially, and then the MDS returned, their counts dropped, transfusion requirements returned, etc. It says they now have to have 2 cycles of Dacogen followed by DLI with more of donor cells. Any thoughts on this response to this reoccurrence? Anything else that they should be looking to do?
So this does happen, and it depends on. Sometimes we look at what the chimerism is. Is it because a patient lost their chimerism, meaning the percentage is not 100% donor, but the percentage starts falling, and a DLI is, the way I look at it is, think about it like a car. There is a difference between giving your car a jump start and replacing the entire battery. A DLI is a jump start, and it's less risk. The thing you want to make sure before getting a DLI is you don't have active GVHD, because that's the risk of DLI, is that you can increase the GVHD because you're infusing T cells. So but given an HMA and a DLI, I think is a good strategy to try to get things under control. But if not, then eventually, the talk would have to be about a second allo transplant, because the first was not successful.
Thank you very much. What is the most common form of GVHD, and when would you typically see GVHD occurring after transplant?
So the most common that you would see is probably skin. And I think first let's delineate that there is acute graft-versus-host disease and chronic graft-versus-host disease. At acute chronic graft-versus disease, we typically say to expect between day 30 and day 100. And oftentimes, this is also why we keep patients near our transplant centers for 100 days, is because of the risk of acute GVHD. Skin is probably the most common, and sometimes it may be grade 1 where we don't even have to give any kind of systemic treatment. We can just give them topical steroid and it kind of works just fine like that. But if it's widespread, if it's more than 50% of your body surface area, we're going to have to give you systemic treatment. I would say after that, GI would be the next common acute graft-versus disease, and that would be nausea. Could be nausea or could be watery profuse diarrhea. And after that would be liver GVHD. Acute GVHD, from my experience, is relatively rare. Chronic graft-versus disease, I would still say skin would be the more common manifestation, but that could be manifested in so many different ways. There's like about 15 or 16 at least different types of skin GVHD by the NIH criteria. And then there's other organ involvements that can occur, liver, mouth, ocular, lots of different manifestations of chronic graft-versus disease. But acute and chronic, I would say skin is the most common.
Thank you. Prior to having your transplant, are there things put in place, treatments that are used to help prevent GVHD from occurring?
Yes. Every transplant has a GVHD prevention plan. That some occur before the stem cells are infused, such as tacrolimus, which can be started sometimes 2 days before the transplant. Often the GVHD prevention plans are done post-transplant, whether it's methotrexate, sirolimus, post-transplant cyclophosphamide, which is a 2-day cyclophosphamide on the 3rd day and the 4th day, Cellcept or mycophenolate, or in some cases, some transplant centers will actually manipulate the stem cells and take out the T cells and then infuse the stem cells with something called CD34 selected grafts. Sloan Kettering, for one, does that quite a bit. So there are different strategies, some before, some manipulating the graft, most after the graft is infused. But every transplant, every allogeneic stem cell transplant has a GVHD prevention plan.
Thank you. Our next question is regarding vaccines. How soon after transplant does a patient begin their revaccination?
The earliest we do is 3 months. But a large part of when we start vaccinating patients is actually contingent on the immunosuppression. If somebody is on, and we've seen plenty of these in the COVID studies, the more immune suppression that you are on, the less you're going to respond to a single vaccination or even a vaccination series. I was just putting slides together about this, and patients had they received a 3rd vaccine, and even in patients who did not respond to the first 2, seroconverted after the 3rd, but still the level of immune suppression, prednisone dose, affected the efficacy of it. So all the vaccinations, we usually like to have patients on as little or no immune suppression so that they can hold their vaccination. But the earliest we would start is 3 months, but we typically start most of our vaccinations at the 6-month mark.
Thank you very much. Our next question is regarding a 73-year-old female with treatment-related MDS. She had an allogeneic transplant in 1991 for CML. She later encountered renal cell carcinoma, which metastasized to her adrenal glands, resulting in a bilateral adrenalectomy. She is now considered intermediate MDS and has received a full cytogenetic response with HMAs. Right now, overall health is good. She's been taking Inqovi. The
Mhm.
RCC is dominant for 3 years. They'd like to know, with the medical history, would she be considered a possible candidate for a transplant?
This is a tough case, and this is something that we would certainly be discussing at length in our selection meetings. Uh, I think you could be considered a candidate because of the risk, because of the response to the treatment, because of the fact that, and it's very important that the solid cancer is not active, and if it hasn't been active in 3 years, that's a good sign with that. The risks that are going to be present is the therapy related MDS does not have great transplant outcomes. It's high risk as you can get, so there is a high risk of relapse in those patients. The second, age, but I don't think I don't at 73, I don't think is really that much of a limiting factor as long as very good performance status. The third, the third would be the comorbidity score. Right now, you would at least get a 3 because of a prior solid organ malignancy, and that's without doing any other workup or knowing more about medical history. So these are one of those things that it really is about the comfort of the transplant center and the willingness of the patient to proceed, because I think there are certainly risks that are going to have to be undertaken with this, given the high risk nature of the disease, and what already I would think there is higher risk of treatment related mortality. But I wouldn't say that you're not a candidate for a allo transplant. I think you would be a candidate to be evaluated for an allo transplant, and based on the workup and discussions, then the decision would have to be made with yourself and the transplant center.
Thank you. Can you have more than one transplant? And if so, does that
Yes.
increase your risk of GVHD?
Uh, I don't think it increases your risk of GVHD. You can have two transplants. Actually, my boss just published in the EBMT the outcomes of second transplants. You can. There are plenty of people who have had a auto transplant and then an allo transplant. There are people who have had two allo transplants because the first one didn't work, or there was a graft failure in the first one. Uh, so it is possible. There are risks of toxicities, which is why typically if somebody has a first transplant, we don't do a full intensity transplant for the second one because of the risk of toxicities. The other thing is, depending on the timing between the two transplants, you may be pretty beaten up and fatigued from the first transplant, so that may increase the risk of toxicities and outcomes in the second transplant. But we've had people who've done. I do have a patient who had a primary graft failure, who got a second transplant and is doing absolutely wonderful. So it's not that it's not feasible. It certainly can be done. The risks, I think, are more inherent to whether it's auto allo or allo allo. and the reason and the timing between the transplants.
Thank you. What's the difference between an allo and an auto transplant?
A auto transplant is using your own stem cells, and the purpose of an auto transplant is not for anything immune mediated. It really is just to give you high dose chemotherapy. Stem cells, have little homing signals that will find their way back to your bone marrow once you infuse it into peripheral blood. And when you give the high dose chemotherapies that we give in the conditioning, you may take months to recover your blood counts. When we infuse the stem cells, it takes about 2 to 3 weeks to recover. So an auto transplant, which is indicated for myeloma, multiple myeloma, non-Hodgkin lymphoma, relapse, promyelocytic leukemia, and testicular cancer, those are purely for high-dose chemotherapy. An allogeneic transplant is not just giving you stems. If allogeneic transplant inherently it's a donor. And the reason we use a donor is not, the donor transplant is not just to get the benefit of the high dose chemotherapy, the conditioning before the transplant, but to get the immune effect against the leukemic stem cell or the malignant stem cell that would be responsible for the disease to relapse. So the way, and even if you have a full HLA match, there are still minor HLA mismatches or minor HLA incompatibilities that exert that immune effect from the donor cell on the recipient, suppressing the recipient cells so that the disease does not recur. I kind of put it like this. So there's a difference between like a twin, but a twin means they're completely, it's like a twin transplant is like an auto transplant, but you want them close enough. You want these two, the donor and the recipient, to be close enough so that they're very similar, so they don't reject each other. But you want it to be just slightly different enough that you get that immune effect to exert that anti-disease activity exerted by the donor on the recipient.
Thank you. This question is in regards to cord blood transplants. Are adults eligible for cord blood transplants?
Yes.
Are they successful? And what are the downsides or what are the pros and cons of a cord blood transplant for adults?
So the cord blood transplants are feasible. They have been successful. They're not widely as used as other types of transplants, even other types of alternative donor transplants, such as haploidentical transplants. The thing with cord blood is what we would call, is very immune naive. It's something that cord blood will learn the immune system. So you don't have stringent matching. I mean, cord blood units are 3 out of 6, 4 out of 6, and that's fine. The issues that come, and the benefit of cord blood is this: one, it's very easily accessible. It's very easy to get cord blood units. And second, the risk of GVHD is exceedingly low, extremely low. So that's great. Now, the issues with cord blood, I will say there's 3 of them. Number one, there are not a lot of centers that have extensive experience with cord blood, like high volume cord blood centers. I would say there's about a handful. I'm going to tell you off the top of my head: Minnesota, Sloan Kettering, Duke, Fred Hutch, Anderson. And those off the top of my head are the big cord blood centers for adult. So that's one. Second, because of the size of an adult, you typically need to give them you need to give somebody 2 cord blood units, and you don't know which one will engraft. So that's also a bit of a wild card in that. But the third one, and this is the most important thing, is because the risk of infection is low. I mean, the risk of graft-versus-host disease is low. The risk of infection and delayed immune reconstitution is high. And that's when you get a lot of issues with viruses, CMV, Epstein-Barr virus, HHV6. You get a lot of these resistant viruses and infection and delayed immune reconstitution. And that a lot of people almost and this is just like hearsay and personal conversations, people may feel more comfortable treating graft-versus-host disease than these types of infections. But it is something that cord blood transplants behave very differently than your standard allogeneic transplant. So, you know, a lot of places do not do cord blood or do very few cord blood. And I think the successes of cord blood really are in these high volume cord blood centers.
Thank you very much. This question is in regards for Fanconi anemia. They would like to know, can a heterozygous mutation positive sibling be a donor for a Fanconi anemia haplo transplant?
That is it. I don't have a great answer for that. I know I would be, I think it's a matter of, I think it's certainly a concern that of to have a carrier. I think the other question is there another donor? Is that the only donor? Yeah, I certainly would be looking for alternate donors. I would be looking for unrelated donors. I may even consider a single antigen mismatch because I don't have a great idea what the impact of that is. I know when we look at anything familial, I do worry if someone is a carrier. We've had instances about familial leukemia, where there's definitely a concern about having a related donor, particularly one that may carry the same kind of gene. It's a great question, and I apologize, I don't have a great answer for that. I would say, in my experience, I probably would look to see if there is another donor unrelated that this is not a concern about, but I can try to get you an answer. I don't have a great answer for that.
Thanks, Dr. Murthy. Our next question is from a patient who has low risk MDS, was recently diagnosed. They're just watch and wait, but they would like to know, should they go ahead and start consulting with a transplant team just to get information or see if they have matches? When should a patient initiate a consult with a transplant team?
Low risk MDS, there was actually an analysis that was done years ago by I think it was Joseph Padala and Corey Cutler, where the risk associated with a transplant in low risk MDS was not worth the benefit. And we don't typically send people with low risk MDS to transplant evaluations, especially if they're watchful waiting or they're only on growth factor support. Now, there are low risk MDS patients that I have taken to transplant, but my practice really is, if a patient is young and has failed multiple lines of treatment to the point where I am initiating a hypomethylating agent, and usually by that time, that's at least 2-3 lines of treatment down the road, then I'm considering it because I'm looking at a patient's quality of life, I'm looking at their transfusion requirements, or growth factor support. And if they're young enough, that still is the only curative option, is a transplant. Early on in a low risk MDS, that risk is not worth the benefit, in my opinion. But later on, if you failed multiple lines and we're running out of treatment options, and quality of life is a big concern, then I would consider it, particularly younger people in that scenario.
Thank you. Why are male donors preferred over female donors?
It's not that male donors are preferred to female donors. It's, I don't have it's multiparous or people or females with multiple pregnancies. It probably has something to do with maternal antibodies that are developed with each subsequent pregnancy, but there is an increased risk with multiparous females donors in terms of risk of graft versus host disease. People like males because especially if you were, I mean, olden times, it was easy because all you had to do was look and see if a blood would churn from XX to XY. But in reality, the main reason we like males is because we don't have to even ask about the pregnancy question. If you have a male, just go with a male. In a young female, I don't have a problem using female donors, but less pregnancies or nulliparous would be more ideal. And younger donors are always favored to older donors. That donor age does affect graft versus host disease.
Thank you. And our last question is going to be, some transplant teams say it's a 10 out of 10 match. Some say 8 out of 8. What's the difference?
The difference is it's the resolution. It's how many matches they're counting. So if you say 6 out of 6, it's ABDR. If you say 8 out of 8, it's ABCDR. If you say 10 out of 10, it's ABC, 10 out of 10 or 12 out of 12, then you're counting all of them, A, B, C, D, P, D, R, D, Q. So the more match, the better. The more it also means how high resolution you're looking at. But the main thing is, as long as at this day and age, people are saying 10 out of 10. So I think, but that's the difference. It's about how many haplotypes they're looking at a match. And it used to be when we only were able to do low resolution, we were only looking at 6 out of 6, which is just A, B, and DR. So though nowadays we look at 10 out of 10 and 12 out of 12. So but if someone's specifically saying 8 out of 8, it's A, B, C, and DR.
Thank you so much, Dr. Murthy, for sharing your time and your expertise in answering all of these fantastic questions from our audience. If you'd like to watch this webinar again at a later time, it will be available on our website within 3 to 5 business days. If you have any additional questions, please send them to us in 3 ways. Email help@aamds.org, call our helpline at 800-747-2820, or you can submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family as we have done for the past 39 years. This concludes our session. Thank you again, Dr. Murthy.
Thank you. It was a pleasure, and I'm happy. I really hope I could help in any way. But thank you all.
Absolutely. Have a great day.
Take care.